Good morning, everybody, and welcome to Palliative Care Updates. This is our first update for 2021, presented from West Auckland Hospice. So much welcome from us, our team here. My name is Celia Palmer, and I'm the Palliative Care Clinical Lead here at Hospice West. And this is a part of an ongoing development, so we'd like to develop our topics and our webinars further throughout 2021 and ongoing. So as we're going through this and you're experiencing this webinar today, please do be interested in any feedback of how we can improve or what's good or works well for you and what doesn't. So today our topic for the day is opioids. Just a few, before we actually start, I'm just going to give you a few housekeeping points around the webinar. So during the webinar, if you've got particular issues for our hosts or panelists, you're welcome to use chat, especially if you've got issues with the webinar or you can't hear people and those sort of issues, then please do use chat for that. We've got a couple of people working in the background, David and Kathy, who are from our HR team, who've done a huge amount of work to get this webinar off the ground, and they'll support you with that. And you could also raise your hand if you need help with that. If you do want to ask a question related to the topic, then please use the question and answers for that, and we'll be using the time at the end to answer those questions. Obviously, you can click leave meeting if you'd like to leave. So I'd like to introduce Dr. Oleg Kiriaev, who's going to be presenting this today. And he is working with us at Hospice West for half his time and also works as a specialist in palliative care down at Middlemore Hospital. He also has university commitments and works with the Department of Epidemiology, Public Health there, running symptom management and advanced symptom management courses, postgraduate courses. So I'll leave you in his capable hands. Thank you.
Thank you for those kind words, Celia. Yes, I've adapted this talk from one that I have given at the university. I've taken out some of the esoteric elements, but I've included some elements that I think are not only interesting, but also clinically relevant and might well help you to use as well as understand the use of opioids in palliative care and become more confident in your own prescribing. So the outline of this talk really will firstly touch upon the endogenous opioid system as well as the opioid receptors. Then I'll focus on the core opioids that are available in New Zealand and provide you with some examples of prescribing templates, at least that I use. I'll move on to the common adverse effects we encounter as well as how we approach them, and then talk about tolerance before finally thinking about opioid-induced hyperalgesia or opioid-induced neurotoxicity. So with regard to the endogenous opioid system, Candace Pert discovered the opioid receptor back in 1975, and this allowed the endogenous ligands to be traced back to pro-opiomelanocortin, POMC, and that's secreted by the anterior pituitary. POMC is cleaved into three different ligands, endorphins, enkephalins, and dynorphins. And each of these has a different selectivity for the three opioid receptor subtypes, mu, delta, and kappa. So apologies for the complexity of this slide, but there's no really easy way of showing the different distributions, functions, and effects of the different receptor subtypes. Though we focus on the mu receptor as providing analgesia, do be aware that all three receptor subtypes. Why do I do that? Sorry, how do I change the screen mode?
That's right. If we go share screen down the bottom there, yeah, and if we select, was it that one that you're using before?
Yep.
That's the right one.
Yep, is that the right one?
That's one. And then if you bring your microphone down to your lower belt.
Oh, sorry. Yep.
Perfect.
Sorry about that, people. Are we carrying on? All right. Apologies for the complexity of the slide, but there's no easy way of demonstrating this, which is essentially the three receptor subtypes, including their distribution, their function, and their main effects. And as you can see, it's quite varied and complex. It includes much more than just simply analgesic effects. So bearing that in mind, I guess, have you ever thought, what is the endogenous opioid system actually for? What is its purpose? So I'll try to answer this in a way that hopefully makes sense to you. So hopefully you're all familiar with the autonomic adrenergic system of fight or flight, in this case, fleeing a bear. But let me ask you, is this the only thing you really need to survive an attack from a bear? I'd say you'd be lucky to get 1 minute's head start. And if we use the analogy of a car, the fight or flight response really is the starter motor of the car. And if that's the case, then what is the actual engine? So essentially, that's the endogenous opioid system. This system allows you to engage in sustained motor activity. It's where the runner's high comes from, but it does more than just provide the runner's high. It's involved in both motivating you to the lead up of activity, as well as preparing you whilst engaging in that activity, in this case, hunting down the mammoth. It keeps in check your tendency to panic and hyperventilate. It stops your gut working because you don't want to be inconvenienced. Your pupils constrict so as to improve visual acuity, and your immune system dampens down because you don't need to be nagged by that gout in your foot. It also masks your awareness of the rib that you've just broken when you crash into one of the mammoth's tusks. And finally, if your sustained labors are successful in hunting down the mammoth, then you'll be rewarded with a dopamine hit so as to keep you coming back for more. Now, I guess if you look at it this way, then the many varied effects of the endogenous opioid system actually start to make sense, and that in actual fact, we've simply just hijacked them for the relief of pain. All of a sudden, the side effects, actually, start to make sense. So that's all I really wanted to talk about with regard to the endogenous opioid system. Let's move on to the common opioids available in New Zealand. So I'll firstly talk about codeine. I seldom use it in my practice, and I'll hope to demonstrate why. Principally, it's metabolized to codeine 6-glucuronide, weak agonist, as well as norcodeine, with no analgesic properties, but still thought to contribute to a lot of the side effects we will experience with codeine. Only a very small amount is demethylated through to morphine, which is the main way codeine provides analgesia. Conversion in the liver to morphine is through the rate-limiting cytochrome CYP2D6. And let's have a closer look at this enzyme and its pharmacogenomics. There are over 80 allelic variations, and people were phenotypically classified into poor metabolizers, intermediate, extensive, and ultra-rapid metabolizers. So individuals who oh no. This is bloody hell. Sorry about that. That's a, oh no. Anyway, let's move on. So these are the codeine preparations available in New Zealand. Oh, now the light's on my eyes. And do be aware that the maximum daily dose should not exceed 300 milligrams. This is not because of morphine toxicity, rather accumulation of codeine 6-glucuronide, which can risk seizures. Codeine conversion we use to oral morphine equivalents is 10:1. Right, let's move on to morphine. So this has two metabolites, morphine 3-glucuronide, an opioid antagonist, and this is morphine 3-glucuronide is thought to have a role in the development of tolerance as well as hyperalgesia and allodynia. Morphine 6-glucuronide is very potent, 3 to 6 times more so than actual morphine itself, but it has a high polarity which reduces its ability to cross the blood-brain barrier. These are the morphine preparations available in New Zealand. And for those who prescribe morphine a lot, it's useful to know both the colorways as well as box sizes. So a few tips when using morphine. Firstly, do appreciate that morphine remains the gold standard and that its qualities in both analgesia as well as side effect are class effects. So for example, what I mean by this is that I do not believe it's appropriate to change to oxycodone simply because a patient develops constipation on morphine. Secondly, many people who get put off morphine because of side effects mislabel this experience as an allergy. True allergy is vanishingly rare. However, convincing them of this, as well as to give it another go, can be quite difficult. If a person is reluctant, then sometimes you literally need to start with homeopathic doses, for example, 0.5 milligrams of the morphine liquid. And the purpose of this isn't to provide any meaningful analgesia, but simply just to demonstrate this to them that they can take it and avoid the side effects. So knowing this, it's always important to co-prescribe antiemetics and laxatives and proactively work to prevent these problems from the outset. Also remember that any opioid titration needs to be viewed as a trial. And as a trial, it's imperative to assess how it's gone. Has it been effective or not? I would advocate a neutral approach to inquiry. Otherwise, you run the risk of coaching the patient if you ask, how well does the morphine relieve your pain? Finally, do be aware of the difference between breakthrough and incident needs. So this is the morphine conversion we use when going from oral to subcut. Essentially very simple, 2:1, and subcut back to orals, 1:2. And this is an example of a morphine syringe driver that I would prescribe. Do be aware, this is the way I prescribe it on a controlled drug script, but I have passed it by our pharmacist who has endorsed it, or at least gotten used to the way I do it. Also, do note that, when I provide pre-filled syringes, I generally try to provide a fairly ample supply, knowing that the pre-filled lasts 3 days, giving them at least 4 to 5 PRNs each day. Moving on to oxycodone, semi-synthetic with no active metabolites. Excretion through the kidney, 60% unchanged. So although it is safer in renal impairment, caution is still required in severe end-stage renal failure. These are the preparations available in New Zealand. Again, the colorways and the box sizes. So for oxycodone conversion through to morphine, once again, we use a 2:1 conversion from oral morphine to oral oxycodone, as oxycodone is twice as potent as morphine. And this is an example of an oxycodone prescription. The sustained release obviously is fairly simple, 10 days with 2 repeats, and the immediate release can be a little bit more complicated because you have to know both the tablet sizes as well as how many tablets to provide them. It might seem a lot, but in actual fact, in people who are on moderate doses of opioids, this is absolutely essential and necessary to furnish them with sufficient supply. So in terms of fentanyl, it's got a very poor oral bioavailability because of extensive first pass metabolism. It's also highly lipid soluble and sequestered in this compartment, which leads to a 3-compartment model. Initial distribution, only 1 to 2 minutes. Redistribution phase, 10 to 15 minutes, and terminal elimination of several hours. Fentanyl has no active metabolites. And because of its very low molecular weight, high potency, and lipid solubility, fentanyl does make an ideal sort of drug to be delivered transdermally via a patch. So the fentanyl drug, when delivered via patch, accumulates in a subcutaneous depot. And it's from this depot that it's subsequently absorbed into the systemic circulation. And this causes a gradual increase in serum concentrations over time. So when you put a patch on, it generally takes up to 12, 24, 48 hours for steady state to be achieved from that patch. And also, when you take a patch off, a similar amount of time is required for that depot to eventually be completely absorbed. So knowing the importance of the subdermal depot, absorption, as you can imagine, is decreased in states of cachexia and increased in states of local vasodilation, such as heat application or febrile illness. So when you want to convert, the time to peak in terms of a fentanyl patch formulation can be anywhere between 20 to 72 hours. So we generally say steady state serum concentrations can be reached after 2 sequential patch changes. That is literally 6 days or a week. Similarly, when the patch is removed, when you want to convert to a fentanyl patch, then it should be applied at the same time as the last dose of the long-acting. If the patient is on a syringe driver, then the syringe driver should be continued for at least 6 hours after applying the patch. But even if you do appropriately convert, opioid withdrawal can still occur because of incomplete cross-tolerance, and I'll touch upon this during the end of this webinar. When converting from a patch to an oral long-acting or a syringe driver, start 12 hours after taking the patch off. Fentanyl nasal spray has become quite popular over recent years, so I'll quickly discuss this. The nasal cavity has a volume of generally 15 to 20 mils, but a very large surface area. The mucociliary transport takes about 15 minutes, which is why we prescribe fentanyl nasal spray as Q 15 minutes PRN. Each actuation delivers 0.1 mils, which is 5 micrograms. And so considering each nostril can take up to 2 sprays comfortably, each application of 4 sprays gives 20 micrograms, which is not unreasonable if a person is otherwise opioid naive. And this is an example of a fentanyl nasal spray prescription. These are the fentanyl preparations available in New Zealand, 12.5 microgram being the smallest patch size. And the fentanyl conversion we use from oral to subcut is 20 to 1. Although fentanyl is 10 times more potent than morphine. We use the 20-to-1 ratio, obviously, to convert from oral morphine through to subcut morphine, and then subcut morphine through to subcut fentanyl. Let's move on to tramadol. I hardly, if ever, use this agent in a palliative care setting. There's several reasons, but essentially, because it's a partial agonist, typically our patient population eventually, inevitably, require a strong agonist. And tramadol competes at the receptor level to diminish the effects of full agonism. And if we were to convert from tramadol to morphine, then we use a ratio of 5-to-1. So we arrive at methadone. As you can see, it's got excellent bioavailability orally and quick analgesic effect. The peak serum concentration is reached about 4 hours post-dose. This is, only the roughest of estimates, as it can range quite widely, anywhere between 8 to 100 plus hours, especially with repeated dosing. And so this is obviously a pharmacogenomic effect, which we have very poor understanding of. Methadone is mainly metabolized in the liver and has no active metabolites. So in actual fact, in both renal and hepatic impairment, it can actually be quite a useful opioid, if not the ideal opioid. But because of its non-linear kinetics, there is no easy way of conversion between methadone and other opioids. And several recognized algorithms are commonly used, but all these algorithms are just an approximation of the non-linear nomogram. It is important to be aware, unlike other opioids, however, that these ratios cannot be used in reverse. You cannot convert methadone easily back to another opioid. There's recently been work by Fudin in terms of trying to merge these three algorithms so as to get a more smoother effect profile, though this hasn't really gained any widespread traction. And it might be something to do with the conversion formula required. So these are the receptor affinities of the various opioids. And as you can see, fentanyl is a pure mu agonist, whereas methadone touches all three receptor subtypes, as well as many others, including NMDA. And this is the receptor that is actually exploited and thought to have a role, especially in neuropathic pain. In terms of methadone tips, I would say if you do consider using it, please phone a friend. And this is the Doctor Direct line at Hospice West Auckland. So we would definitely like having a discussion with you if you are thinking about starting this agent or have a complex pain situation on your hands. So in terms of equianalgesic tables, this is a standard table that I use. There are a lot of different variations. They're all fairly similar, but I think the key really is to use one table consistently, and even better if everyone in your team, if not your region, is able to use the same table. Do be aware that these equianalgesic tables really are based on historic studies, often very small numbers, either healthy participants or post-operative populations. Very different, as you can imagine, to our palliative care population. Also, a lot of these studies only use a single dose or have limited routes of administration. So these tables have been extrapolated out. The ratios can change also between acute versus chronic dosing and also be different in reverse. None of this is really taken in any of our equianalgesic tables or prescribing practices. nor are we really able to take into account, inter-individual variation. If a person is elderly, for example, or has any other, factors which might affect the effect that opioids have on them. So I guess this really means that if you do have to undertake an opioid conversion, then it's essential to really monitor them closely over the subsequent days for both opioid withdrawal as well as overdose symptoms, as these can actually be quite subtle and easily missed. So moving on to opioid side effects, here's a list of the common side effects, and we can go through some of them in a little bit more detail. So nausea and vomiting, though common, isn't inevitable. Mostly seen at initiation or dose titration. It results from stimulation of the chemoreceptor trigger zone, as well as increased vestibular sensitivity, but also from gastric antral tone being increased, as well as decreased gastric emptying. We expect tolerance to be developed after a short number of weeks. And I guess whilst this is happening, it's important to have prophylactic PRN medication. Domperidone is the one we typically initially recommend. Constipation, on the other hand, is fairly ubiquitous, almost universal. And this is a direct effect both on the gastrointestinal tract by prolonging colonic transit, as well as also an indirect effect, centrally mediated through a reduction in the urge to defecate. Also, the other thing to be aware is that tolerance never develops. So I would say laxatives are compulsory at initiation, be maintained throughout treatment, and reviewed every time an opioid titration is undertaken. Sedation and sleep disturbances are also common, especially at initiation and dose titration. Once again, with tolerance most likely taking a few weeks to develop. It's important to remind patients of the LTSA driving restrictions over this period of time. A few patients never really developed complete tolerance. So after reviewing associated factors or reversible factors, sometimes a dose reduction might need to be undertaken. It's important not to confuse these side effects with the catch-up sleep that sometimes patients require in the case where they've had severe persistent pain, which have exhausted them and finally now been relieved with a dose titration. We occasionally do see more overt confusion, especially in the vulnerable elderly person with underlying cognitive impairment, be it known or sometimes unknown. Again, it might be transient, but sometimes it can uncommonly precipitate an irreversible decline. Workup is as for in undifferentiated delirium. There's also a body of literature, a growing body of literature that actually suggests the very real harms of using opioids, especially in elderly in the setting of non-malignant or non-cancer pain. It does lead to subtle cognitive impairment as well as increased their morbidity. So, I'm always a little bit hesitant in terms of using opioids, even if a person does have cancer, if the pain syndrome they're experiencing is from their non-malignant comorbidities. So respiratory depression always seems to be a cardinal side effect on clinicians' minds, especially junior staff. And I believe this results from biased undergraduate education. I only wish they had as much thought given to constipation as they do to respiratory depression, as constipation causes far greater morbidity. But anyway, respiratory depression mediated through the mu receptor at the level of the medulla and affects all phases of respiration. Tolerance develops very rapidly. And so I believe it poses very little, if any, risk in people who have already been established on opioids. do be aware it is antagonized by the presence of pain, and that naloxone should only be reserved in those who have been, in those who are proven to be hypoventilating as a consequence of the opioids. I do not feel it is safe practice, in actual fact, to co-prescribe naloxone in case of need. These are some of the other side effects that can occur, that can catch you out, as well as some of the factors related to them. So do be aware of these as well. So moving on to the social implications of opioids, I guess it's true to say that, you know, the role of opioids in society is a truly dysfunctional relationship between the two. But as major prescribers and advocates of opioid therapy, it's a conversation that we can't really avoid, and we can't really ignore the wider effects of opioids on society. And I myself have often wondered, of the opioids I've personally prescribed, what proportion actually ends up being diverted. You know, I have no idea, but I would imagine it would be a significant proportion. And I'm just picking a number out of thin air, about 20 to 30% potentially. And it's a question that does occasionally crop up clinically as well, which I don't think we attend to very well, especially in patients who have been previous IV drug users or substance users. I think as clinicians, unfortunately, we tend to automatically jump to assumptions. We draw conclusions on a person's lifestyle choices in the past, and we start bandying around various labels, which, you know, does risk making some value judgments. So I think, you know, at least if nothing else, we are responsible for the terms we use and how we communicate. So it's important to actually get a good understanding and use the appropriate terms to describe these situations that we encounter clinically, without trying to introduce our own bias or ascribe motivations or passing judgment. There's a spectrum. There's a spectrum of how opioids are used by the patient, and at one pole of the spectrum is medical use. I believe even at this end, it's important for us to acknowledge the non-physical effects of opioids that we exploit therapeutically, even if we're not aware of doing so. You know, I've discovered when I've started asking about opioid effects from a neutral stance. So when I ask, what do you notice when you take your morphine? Then that really, I'm often surprised the response I get, that people don't talk about the pain. People just simply say, "Oh, it gives me more energy. It allows me to cope and see the day through," or that it simply allows me not to care so much about the pain. So. Yeah, you know, I think non-physical effects of opioids are at least, you know, a significant proportion of the therapeutic effects they provide. However, at the other end of the spectrum, of course, is opioid use disorder, which is a diagnosable mental health disorder. And if a person does have this, then obviously treatment should be provided. And although patients use terms like addiction, I think you should really refrain from doing so yourself in your professional setting, as this term now holds very little clinical relevance or use. Other terms which we use loosely are dependence, and it's important, I think, that you have a good understanding of dependence so that you're at least able to provide an explanation to patients, because often this is one of the main fears that they have when commencing opioid therapy. Pseudo addiction is interesting, as some clinicians doubt its existence or validity. I've occasionally encountered patients with a history of substance use who because they experience continued stigma and difficulty in getting their pain needs met, they then adopt what appear to be drug-seeking behaviors, But the key is when you actually do meet their pain needs and acknowledge them, that these behaviors actually resolve completely. And finally, tolerance. So this is a normal, expected physiological response to continued opioid dosing and usage. And the hope really is, at least clinically, that tolerance to side effects occurs before tolerance to analgesic effects. But inevitably, there is tolerance to analgesic effects, and this narrows the therapeutic index of opioids. Unfortunately, what we don't know is whether tolerance is continuously progressive or whether it actually plateaus out in steady state with constant dosing. So understanding tolerance brings us to the concept of cross-tolerance. And this occurs when similar drugs bind to the same receptor class. And this allows a patient to be tolerant, for example, say to oxycodone, having become tolerant to morphine without ever having taken oxycodone in the past. In appreciating cross-tolerance allows us to think about the situation of incomplete cross-tolerance. Because the reality of opioid pharmacotherapy is that there are 3 opioid receptor subtypes, and we know that different opioid compounds have different affinities to these 3 receptor subtypes. So, for example, taking this diagram, which hopefully allows you to understand the concept of cross-tolerance, let's take drug D in purple here. So if you're converting from drug D to any of the other drugs, then you would expect complete tolerance. However, if a patient is on, for example, drug A, and you're converting them through to drug C, then they would have cross tolerance. But if you're converting them through to drug B or D, then they would have incomplete cross tolerance. You might need to take a moment to reflect upon this so as to get it clear in your mind. But the typical sort of situation we encounter, as mentioned earlier, is fentanyl, because fentanyl is a pure mu agonist, whereas the other opioids act on all 3 opioid receptor subtypes. So thinking about opioid switches brings us to the final topic, which I want to address, which is opioid toxicity, opioid hyperalgesia or neurotoxicity, all interchangeable terms. So essentially, it's a state of nociceptive sensitization, and that means pain paradoxically increases with further doses. We don't know of the exact mechanisms, but I've outlined a few postulated mechanisms here. But more importantly than that is for you to be able to confidently recognize it in a clinical setting. So typically we see it in the context of a pain crisis in people who have already been established on an opioid regime. And they can experience severe unremitting pain requiring frequent PRN doses, usually exceeding what they take in background doses. The initial symptoms can be quite subtle, but essentially there's not only a change in the character of the pain, but also of the patient's level of alertness and attention, if not outright consciousness levels. The pain becomes more diffuse and nebulous, difficult to pin down. The PRN doses have little, if any, effect and can actually provoke more pain. The patient can develop signs of allodynia or hyperesthesia, as well as dysesthesia. Myoclonus is also typically seen and is fairly reliable, but only in settings where a person doesn't have any other reason for myoclonus, such as, cirrhosis or uremia. So the opioid toxicity occurs typically when a cycle of pain is set up with initial misinterpretation of the clinical cues that leads to an inappropriate opioid titration. And so a person gets into the cycle of continued opioid escalation therapy. Yes, they might have benefited partially from the initial titration, but the benefit they receive from each and every subsequent titration diminishes, and the burden of treatment increases, so much so that eventually you can't deny the fact that the person is opioid toxic. So what do you do when you get yourself into the situation? Well, hopefully you don't get yourself into the situation, because I truly believe that, you know, every time a person is rendered opioid toxic is an example of a failure of assessment and management. It's a failure to recognize, you know, the fact that the person has whole pain, and that there are important non-physical elements that have been neglected in the process, and a unimodal approach of simply just resorting to opioid PRNs and increasing opioid background doses is applied. So, but when you do get into this situation, then essentially the options are fairly limited. One of the options we do use is opioid switching or rotation as a means of breaking the cycle. So typically, if a person becomes opioid toxic on morphine, then we would rotate them onto oxycodone. If they become opioid toxic on oxycodone, we might, for example, rotate them onto methadone. I generally don't like rotating onto fentanyl. I find that the quality of analgesia it provides is not as robust as the other opioids, and also fentanyl, especially in the syringe driver, is limited by volume issues. But I don't really want to talk too much about this, as it is a difficult area of practice even for us, let alone for you. So I wouldn't expect a generalist to engage in opioid rotation if they do experience, this predicament. I would suggest, if you have a patient with a palliative diagnosis that hasn't responded to an opioid initiation or one round of titration, that you let us know about them. If not, refer them directly through to hospice formally. So this really brings me to the end of the talk. Apologies for the technical glitches. Hopefully we'll be able to provide a slicker webinar in our next session. Thank you.
Thank you very much, Oleg, for that comprehensive overview of the different opioids that we tend to use in palliative care. There are a number of questions and we have got a bit of time. So if you're happy to take some of those, that would be wonderful. The first question that we've got is around the breakthrough and incident pain. I think you mentioned it briefly in your talk, but I wonder if you could go into a bit more detail about the difference between those types of pain and how to manage them.
Yes, of course. Into mute. So what I mean by breakthrough and incident pain is, so for example, a person is established on a background regime and they are able to resort to PRN medication to manage any further pain over and above the background. So they may experience what I refer to as breakthrough pain, in which there is spontaneous pain, there is spontaneous breakthrough pain that isn't associated with any particular factors or incidents or movement, for example, eating, those sorts of things, versus incident pain, which is actually provoked by something in particular. And so knowing that and being able to discriminate between the two, we would advocate not increasing the PRNs. For example, if a person typically only experiences incident pain. So no, let me rephrase that. Not increasing the background if a person typically only experiences incident pain, because even if you were to increase the background, they would still have their incident needs, because they would still be engaging in activities through the day and still requiring 3 to 4 PRNs to meet those needs. If you were to increase the background, that doesn't really change that. However, on the other hand, if they have background pain, if they have to have breakthrough pain, then increasing their background hopefully does meet that need, so as to reduce their PRN dosing.
Thank you. Yeah, I think that's a great distinction. And obviously, if we increase the background, sometimes in the light of only incident pain, that's when we can run into a bit of trouble with some opioid toxicity as well. I'm sure you've experienced that as well, Oleg. The second question we've got is around PRN dosing, and wondered if you could go into a bit more detail about how you decide what the breakthrough dose should be.
So quite simply, the breakthrough dose I like to use is a proportion of the PRN dose I calculate is a proportion of the background. And I generally use a ratio of 1 in 5 to 1 in 6. So for example, if a person is on 30 milligrams BD of Emeslon, that makes a total daily dose of 60 milligrams in terms of their background dose. And so 1/6 is 10 milligrams. So their PRN dose is Sevrodol 10 milligrams. And it's always important when you're titrating an opioid and increasing the background dose, not to neglect also a commensurate increase in their PRN dose, because occasionally, we do see people who've had several titrations of their background and they've still remained on the original PRN strength. And they say, and they approach us and say, I take the PRNs, but they just don't seem to be working. Well, in actual fact, that's because there's been a slippage that's occurred.
Thank you. That's great. I guess there's just one more thing that I thought it would be useful for us to maybe talk a bit more about, and that is going back to fentanyl patches, because sometimes I think people run into trouble with those. Partly it's the way that they've prescribed and dosed. So we know that the number of micrograms they're prescribed in is per hour. Do you want to comment a bit on increasing the fentanyl patches and how the dose of that, the implications for the dose of opioid someone's taking?
Yeah, no, I think it's a mistake that we occasionally do see when a clinician sees that a fentanyl patch of 12.5 micrograms. Gosh, that's a tiny dose. I can just whack that on without any problems. But as Celia's pointed out, that's 12.5 micrograms per hour that's delivered. And so a 12.5 microgram patch is equivalent to 60 milligrams of morphine per day, which is, if you think about it that way, not a small dose. You wouldn't put a elderly person automatically on 60 milligrams of morphine a day. However, clinicians do it with a fentanyl patch. I, after all these years of practice, still always go to my conversion chart whenever I'm converting between different opioids and double check. I've incorporated this into my routine practice, and this is just a personal safety measure that I engage in. And so I never try to carry the conversions typically in my head. I always go to a conversion chart for my own safety more than anything else. I hope that answers the question.
Yes, thank you very much. And I think the other problem is that obviously that only patches that can be prescribed at 12.5 micrograms, and you have to go up to a 25. So that causes us some difficulty. I mean, it's probably rare, isn't it, that we would double somebody's opioids, and yet when people increase a patch, that's often what they're doing. So it's again, if you do want to talk to one of us about that, then please do use that number that Oleg put up, which I'll repeat for you. That's 09834 9757, and you can speak to one of the doctors here if you've got any queries. We haven't got any more questions coming in at the moment, so I'd just like to thank you very much for your time and signing in to hear the webinar today. It is something we are going to develop further, so we will be asking you for your feedback and what we can do to improve. I'd like to say a huge thank you to Kathy and David from our HR team who've done a huge amount of work in the background, and to Oleg for sharing his experience with us today. And we look forward to speaking with you again soon. Thank you. Thank you.